The original technology was this benchtop unit with a very small surgical robot portion based on something called a Delta. It weighed about 150 pounds and it was kind of difficult to get into position. So we already knew there was an issue there just in terms of getting it into the surgical field. A master's student was working on a project where they would mount the robot, the Delta, to this larger device that stood on the floor. We called it the PPS, the Passive Positioning System. And the PPS had a joystick that would allow you to move the Delta over the patient's head and then give you the maximum amount of value from the limited amount of work volume that it was able to offer. So that was cool, and we took all of that and we set a date for the next major otolaryngology surgical conference, and we told the entire team, okay, we're going to take what we know from the licensed technology and we're just going to build one that looks a little bit more commercial. We'll try to make some decisions along the way, but we're going to take it to this conference and we're going to get hands-on surgeon feedback, and we're going to learn from the surgeons if this thing is really going to be helpful in the OR. And so that became the birth of the Mark I. And with the Mark I, we still had the big Delta robot. Now it was a little bit bigger, and it was mounted to a version of the PPS that didn't have a joystick. So instead, what we did was we created these brakes, and you hold the brakes, move the Delta into position, let go of the brakes, and it would freeze in place. At least that's what we thought. And we built all of that. We made covering for it. We had the Mark I, and this portion on the outside was affectionately known as the flying trash can. As a general rule of thumb, I think when somebody starts referring to a portion of what could be a pretty expensive surgical robot as a trash can, you've probably already got some kind of design issue that you should think about resolving. So that was foreshadowing for things to come. And anyway, we built the Mark I. We took it to this conference. We got over 80 department heads from otolaryngology centers around the world to get hands-on experience with the robot. It was, at this point, pre-clearance, so the way we pulled that off was a lot of fun, different story. But we had over 80 surgeons just sit on the robot. They were doing different exercises, some of which can be found on the internet, with a little spiral that reminds you of that old kids game Operation, except scaled down a lot. And we were getting just incredibly positive feedback from everybody that was using it. We've got them on camera. They're just excited. They're like just kids in a candy store, and they're like, just, oh my gosh, this is incredible. Can I do this? Can I do this? Can I do this? And so we're getting just tons and tons of spontaneous feedback. So going to this show was a golden opportunity. We had about a dozen interns with us in the booth, and I think it was about a 10-page questionnaire. And our hope was that as a surgeon finished and then left the booth, one of the interns would basically just chase them to wherever they were going and ask them the questions from the survey, fill everything out the best they could, and maybe we'd get like 6 pages out of a 10-page questionnaire filled out. That was the bar. And what happened instead was the surgeons would finish. They wanted to know more. They wanted to know more. What do you guys? How can I help you? I want to take this technology to market. It was amazing, just the energy that we were already experiencing from people. So the surgeons would sit down at the table with one of the interns, and they would go through with the pen in their own hand, and they would answer all the questions. And then they would flip the document over, and they would draw their OR, and they would give us additional information that they thought would be helpful to us in making sure that this robot was really going to be something that they would and could use in the OR over and over again. So the feedback that we got was just amazing. And that was the Mark 1. We did learn a few negatives as well. So that flying trash can, which was the Delta with a little bit of covering around it, it was in the way. It just wasn't working. Visually, it was a little bit of an eyesore. It just wasn't that great looking. But also, it would occasionally bang into the boom from the surgical microscope. So that's an automatic fail right there. But also, just depending on the light, it could cause weird shadows. So it just wasn't working. So we knew we needed to get away from that original paradigm of a small Delta robot attached to some sort of mobile base. That had to go. And what we then did was the Mark II. So the Mark II's biggest change was we took the Delta robot and we just made it the size of the cart. It's the size of the entire chassis. And this gave us a huge work volume. Now, we still had to maintain the original level of precision and response speed from the very first Mark Zero, but we were now scaling it up very significantly. We also wanted to improve sourcing on some of the parts. So looking back, this might not have been the best decision in the world, but we decided to just try to build the robot from completely off-the-shelf parts. So McMaster catalogs and everything. We were just trying to find parts that were already being manufactured in mass and use those to build the robot. And for the most part, it worked. We ended up with a robot that was now, we had signed up a strategic partner from a spine surgery implant company, and they were seeing the value of using this robot with cooperative control for doing not only things like spine fusion, but also doing soft tissue work in the spine. So they were really seeing this robot in ways that we had not originally envisioned. So that was pretty exciting. In addition to that work volume, we still had a great deal of portability. There was a little break on the floor. You just pop it with your foot, roll the robot from one room to another, plug it in, get it started, and away you go. So this was really showing us a lot of promise. Just going to the catalogs to getting off-the-shelf parts wasn't always giving us parts that worked the way we really needed them to. So for example, there are these joint pieces for the Delta. The off-the-shelf components that we found definitely allowed the range of motion that we needed for basically kind of like a shoulder socket. But they weren't as frictionless as we hoped. And so we ended up having to do manual hand polishing inside the receiving portion and the kind of the round portion that went into that. We had to basically sit there and hand polish those things until we had a really frictionless, perfectly spherical surface. And that's a lot of hand tooling. So we took everything that we learned, we took the basic chassis design, all of that, and we really focused on manufacturability while maintaining all those really important criteria that we had learned along the way. And that brought us to the Mark III. This was the robot that we submitted to the FDA as a de novo clearance, and 120 days, 119 days after a substantive review, we became the first cooperatively controlled surgical robotic assistance for microsurgical procedures. So that was pretty exciting. The Mark III definitely looks a lot prettier. We've got a long way to go with industrial design to really dial it in. But we didn't want to get too crazy even with this version, because we wanted to make sure that in the OR with live patient settings, we wanted to make sure we had functionality first. We wanted to make sure that it was working really well. We had a long list of surgeons that were still bugging us from that original conference. When can I get a robot? When can I get a robot? I'll do cadaver studies. I want to publish. It was fantastic. The activity from those surgeons, remembering who we were, couple years later, after COVID and everything, still coming after us to get access to the robot as soon as possible. So we knew we had plenty of surgeons that were ready to take it as is. We would get that kind of feedback and then go to the next design. So what's the Mark IV going to look like? Probably the same basic design, but hopefully a heck of a lot prettier. And then we'll continue to expand from there from a commercialization standpoint and really see, I think, a lot of new uses for the robot as we add additional indications and additional instrument support. There's a lot in store. There are a lot of research avenues that we're continuing to work on with Johns Hopkins. So where this robot ends up in the future, I think is going to be really exciting, and I think it's going to surprise a lot of people.